All right, it's 8 o'clock. Good morning. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and it's my pleasure to welcome you this morning. Really looking forward to hearing from Dr. Tait, who I've heard has an extraordinary wealth of experience in this field, medical child abuse in the perioperative environment, and we'll get to that in a moment. But I just want to call your attention to a couple things. First, obviously, is the CME and MOC process shown here on the left. And then also want to call your attention to the next 2 weeks, really quite an extraordinary lineup. We are really, really pleased to be hosting Dr. Monica Goyle, who's at George Washington University School of Medicine, and we're going to be co-hosting this grand rounds with pediatric emergency medicine. Monica is really an undisputed national or international leader in child health equity, health disparities, and pediatric emergency care. And so we have a really fun few days planned with Dr. Goyle next week, and it's going to be a wonderful grand rounds. And then also very, very fortunate, finally, we've been for a long time talking about having Dr. Friedrichsdorf down to give us pediatric grand rounds in his role leading the palliative care program up at UCSF. And so Justin Baker, our new chief of quality of life and palliative care, invited Dr. Friedrichsdorf down to join us, and that's also going to be a really important pediatric grand rounds. Next slide, please. And we will do our university land acknowledgement that we sit on the ancestral land of the Mwaka-Ohlone tribe. The land was and continues to be a great importance of the Ohlone people, and always pleased to do this acknowledgement. And next slide. It is that time of year where we are coming up on the Pediatrics Research Retreat, which is such a wonderful event in the springtime and a great chance to bring our entire research community together across the Department of Pediatrics, from our postdocs to some of our more established faculty, and also a chance to meet and in some cases hear from some of our newer faculty who will be giving lectures. And the Grand Rounds Committee, the program committee always does a really wonderful job of a good mix at this event. And the next slide. And with that, Melissa Egge, who's part of our SCAN team in the child abuse program, will introduce today's speaker. Welcome, Melissa.
Dr. Aidan Tait is a board-certified pediatrician and pediatric anesthesiologist who completed all of her training at Stanford, graduating from the combined pediatrics anesthesia residency in 2020 and the fellowship in 2021. She recently returned to the pediatric anesthesia division as clinical assistant professor after spending 2 years in private practice. Prior to residency, she attended UC Berkeley UCSF Joint Medical Program, where she also obtained a master's degree in public health and did several international research and clinical projects in Brazil and Angola. While at UC Berkeley, she developed an interest in research projects and blend the clinical realm with questions of human rights, medical ethics, and resource inequality. Her ongoing research into medical child abuse, done primarily in collaboration with Dr. Alyssa Burghardt, is a natural extension of these interests. I met Aidan a few months ago in San Diego, where she presented this talk at an international child abuse conference. Her research and presentation were very well received. On behalf of the Suspected Child Abuse and Neglect SCAN team, I am pleased to have her speak on the topic of medical child abuse in the perioperative setting during Child Abuse Awareness Month. You may have noticed we've set up blue pinwheels around campus as a reminder. We aren't at a point where we can keep kids from being harmed, but we can prevent the next instance through recognition and action. Thanks, Dr. Tait.
Good morning, everybody. I hope you can hear me. I just got over a well-timed bout of laryngitis in time to be able to speak this morning. I actually gave a little talk on this over the weekend and was more impaired from a speaking standpoint. So before we get started, I'd just like to set the scene of what I would like you guys to take home from today's talk. And there are 3 main points I would like us all to think about while I'm speaking, and then perhaps at the end we can answer questions or have a discussion around this so that it's more informal and educational. The first is that victims of medical child abuse frequently present to the operating room where I work for surgical and other procedural intervention, both in the United States and throughout the world, given that our case studies are global in nature. The other thing, especially people in pediatrics need to know, is that your surgical and anesthesiology colleagues have limited to no training or real understanding of this phenomenon known as medical child abuse. And the third thing, which is its own talk, is that multi-specialty, multidisciplinary approaches to detection and diagnosis and intervention of this disease are critical, and that the perioperative team should be included in these discussions. I have no conflicts of interest to declare to you guys today. I'm just here to talk about something I'm passionate about. And so who are you? This is a question I get sometimes when I come to meetings where I bring this up, because I'm a little bit different than the average bear who's interested in this topic. As Dr. Egge mentioned, I'm board certified pediatrician, anesthesiologist, and pediatric anesthesiologist. I did all my training here. And my training makes me uniquely qualified to care for medically complex infants and children throughout perioperative spaces and procedural spaces in the hospital. That might be an LP for a general pediatrics patient. That might be an emergent craniotomy. That might be a liver transplant, might be an MRI. I can go a lot of places and do a lot of things, but I'm not a child abuse expert. I'm not somebody who's trained in child abuse pediatrics. I'm somebody who cares about this topic, and I'm very happy to have had the expertise of people like Dr. Egge and Dr. Stewart to guide me in some of the other research and clinical points of this topic. Before we get into what I'm talking about, we should define the entity that is medical child abuse. This was defined in 2009 by Rossler and Jenny, which is a form of child maltreatment in which a child receives unnecessary and harmful or potentially harmful medical care at the instigation of a caregiver. So somewhat popularly known as Munchausen syndrome by proxy, but recategorized as medical child abuse in this writing in 2009. And this quote puts it very bluntly and dramatically and tragically for all of us who take care of children. The children are paraded before the medical profession with a fantastic range of lies. The children are injected, suffocated, poisoned, phlebotomized, lied to, and lied about. The medical profession, generally with an eagerness seen as malignant only in retrospect, investigates and reinvestigates, operates, prescribes, and gives attention and solace. And as somebody who does a lot of invasive procedures on children, this quote is really devastating to read aloud. So what is very unique about medical child abuse as a type of abuse is that well-meaning physicians and other medical providers are unknowing or unseen participants in the abuse of a child. It's like we've been co-opted. We're trying to help and we're not. And I can say this because I am a physician who has participated in the abuse of a documented victim of medical child abuse. And I've also likely been involved in cases in which I did not know that medical child abuse was happening. And I'm assuming, based on where we work, that this is something that many people listening to this talk can identify with. A question that I get a lot is, why does an anesthesiologist care so much about this? You know, this is not a typical research interest or even clinical interest for somebody who's focused a lot on airway breathing and circulation, sometimes up to 24 hours a day. And I admit it's a bit of a niche interest, and it's one that's become a really dominant part of my research life. And it started with a pretty unforgettable clinical experience that I can share with you today in some detail. So when I was a first-year anesthesia resident, I had done my intern year in pediatrics here, and I was on my pediatric anesthesia rotation. And as anyone, there's a few anesthesia trainees in the room. Anesthesiologists rely heavily on the electronic medical record when we are doing our chart review prior to anesthetizing a child the next day. So as I did on almost every afternoon, when I was assigned my cases, I went through the chart to look at who I was taking care of. Sometimes this is really cursory. 3-year-old, healthy, TNA, never seen us before. Make sure they don't have a cold, proceed. Oftentimes at Stanford, these children are exquisitely medically complex. They're followed by multiple subspecialty services. And so the first thing I do to anchor myself is I open the anesthesia tab, because I want to know how many anesthetics they've had, if they have had any problems with anesthesia, if they have a difficult airway, if they have allergies I should worry about, etc. And for this particular patient, I opened the anesthesia tab and found that this child had had somewhere between 16 and 18 anesthetics in the last 6 to 8 months. And that's not totally uncommon, right? At Stanford, we do liver transplants, we do heart transplants, we do complex bone marrow transplant patients. We have really complex neuro patients who need sedated LPs and MRIs. But this was an outpatient. This was someone coming from home. And I thought, that doesn't feel right. That's not normal. And so I just filed that away. And the next day when I met the family, I felt that internal sense of this doesn't feel right in terms of what the parent was advocating for and what I felt the child needed medically. Excuse me, I skipped a slide. And I eventually took care of this child another time, and it remains the only time in my career where a caregiver was trying to give me an argument to intubate their child when I didn't feel like that was necessary. And it is the only time that has ever happened to me. Usually my patients' families are like, oh, you have to place a breathing tube? I'm like, yeah, for a craniotomy, I do. For a tonsillectomy, I do. But this was stunning. You know, I felt like I was being pushed to do something medically from a savvy parent trying to guide me to a decision that I didn't feel like was medically indicated. And, you know, one night when I was on call, after one of these cases that happened with this patient, I happened to be on call with Alyssa or Dr. Burgart. We weren't friends yet. We weren't colleagues or collaborators yet, but we were just speaking socially at the front desk, as you often do at the end of a long day of cases when you plan the night ahead. And I said, you know, I did something a little Munchausen-y today. I didn't know how else to say it. I didn't know there was another term for it, but I just said it out loud. I didn't know that she was an ethicist, really. I didn't know what her clinical responsibility is in the hospital. But what I found out later was that this was the first domino in a series of dominoes to fall for this child. That over the ensuing 6 to 8 months led them to being removed from the care of their family and improved medically. So what happened then was I didn't know everything that had happened, but about a year later, I run into Alyssa by the train elevators and she says, we should look at this. We should look at the procedural burden of medical child abuse victims and use this as the inspiration for a discussion of how this manifests in our work environment. And we recognize that these children are very likely to end up in our hands in the operating room. So as I mentioned, anesthesiologists take care of children having invasive, indicated, clinically appropriate procedures all the time. We know what passes the sniff test a lot. I do a lot of G-tubes. I do a lot of other cases where I'm like, that makes sense. As I mentioned, we rely significantly on the EMR and we make anesthetic plans the night before surgery. If I'm working alone, I do it myself. If I'm working with a resident or fellow, we have a conversation about the patients over the phone before the cases start the next morning. I read as many notes as I can get my hands on. I read the chaplain notes. I go look in Care Everywhere. I read the social work notes. I'll read the dietitian notes if I'm doing an outpatient GI patient who's got failure to thrive. Like, I try to be as comprehensive as I can be, which I credit to some of the training I received in pediatrics. Another thing people who don't do anesthesia might not understand is that a major cornerstone of what we do is ensuring patient safety. And that is up to and including canceling a procedure if it's not safe for the patient at that time. And I've had to do that several times for both children and adults. It's not the right day. If the potassium is 7 and it's elective, we're not doing it. And that part of what we do is we're constantly calculating procedural risk and benefit. And we have to decide if that surgery is likely to be therapeutic to the patient. Oftentimes, the riskiest part of any child or adult surgery is what I'm doing to them. Inducing anesthesia, securing their airway, maintaining anesthesia for hours, dealing with any intraoperative complications that might come up, emerging the patient from anesthesia, ensuring their airway is safe for extubation and afterward. The other thing I tell parents, sometimes we have parents come into the OR for induction or to the MRI suite, and I tell them, once I put that mask on, it's like a flight. Once the wheels are off the ground, I have to keep going. We've made the decision, we have to keep going. The safest thing to do is to keep going in that scenario. Sometimes the safest thing to do is not to go at all. But once you've started that case, you have assumed responsibility for the risk of that anesthetic. And you have said tacitly, the benefits outweigh the risks. We can do this. Or that you have no choice in the case of a surgical emergency where nothing is optimized, but you don't have a choice. These are my children. And this is what I tell my patient's family in every case, every day when I'm talking to parents. I say, my job is to keep your child safe, comfortable, and asleep. All of those things work together in the operating room. But my absolute number one priority at all times is your child safe. I said this 5 times yesterday. I believe it. I believe it passionately. It is the number one job of an anesthesiologist. And so when I think back to that child who was in my operating room, I think were they safe the entire time? Absolutely. Did the benefits outweigh the risks? Absolutely not. Absolutely not. And I always think of my children when I'm thinking about keeping kids safe, but I don't feel like I kept that child safe. They were medically safe, but that wasn't the problem, right? So that's an introduction to why this question is so compelling to me and why I do the research that I do with this amazing team of people. This is who we've recruited to join our team. So it's myself and Dr. Burgart, I'm an ethicist, and many of you have met her in that capacity. She's also an outstanding clinical anesthesiologist in the operating room. Dr. Christopher Stewart lent us expertise from the child abuse side. Dr. Eggy's also been instrumental in thinking of subsequent projects to do with this data. And then I have these 2 librarians on speed dial because this is a major archival project, and Amanda Woodward and Evans Whitaker, very, very helpful. So what did we want to do? We wanted to understand the procedural and surgical burden experienced by medical child abuse victims and study the common presentations of MCA in the perioperative environment. We also just wanted to know, what surgeries are these kids having? What should raise our concern when we are taking care of these people in the operating room? We wanted to look at what we produced versus what's already been published in larger case series in the literature. And in particular, given what I do for work, I wanted to advocate for the importance of MCA detection and reporting in the perioperative workspace. I have spent a lot of time thinking about the limitations of this research because I've been deep in the weeds reading case reports. First of all, as pediatricians, you probably understand this is an under-recognized and under-reported phenomenon. It's not always diagnosed. You can't have a case report if you don't make a diagnosis. It's scary to diagnose this. It's stressful. This is research that's heavily reliant on rare retrospective case reports. And then the other thing, as I mentioned at the top, is in the last 15 to 20 years, there's been a changing understanding in how we recognize this phenomenon and what we call it. And it's called by many different names. And I think people can get a little bit confused. Sometimes I think people think I'm talking about physical child abuse. I'm not. The last thing, because this is global research, is there are very, very diverse, heterogeneous medical, cultural, and legal norms represented in these case reports. Somebody in the Middle East, in Southeast Asia, in the UK might have a different lived experience and a legal infrastructure than what we have in the United States. So before I get into the data, I want to just define this for you so that you understand what I'm talking about. So Munchausen syndrome by proxy was defined by Meadow in the UK in a seminal case report in 1977. And from there was increased recognition of this phenomenon. But I've read all these case reports from the 70s and 80s, and they're very heavily reliant on the paradigm of who is the abuser and why are they doing this, like psychopathology of the caregiver, often the parent. It's been troubling as a mother to read the way some of these mothers are depicted in very gendered, old-timey terms in these case reports. And so there's been this advent of terms that you can see here. Actually, Munchausen syndrome by proxy was never included in the DSM, but factitious disorder by proxy was. And now we call this phenomenon medical child abuse, because this is a diagnosis that puts the child at the center. What the parents' motivations are to me are less important than that we have a child who's being abused. The child is the problem. The motivations of the parent, to me, or the caregiver, are secondary at best. So how do you come up with an epidemiological framework for a rare underreported phenomenon? It's very difficult. And prevalence, I saw huge variations with like decimal point and multiple zeros a number to single digits. And I found one prospective study from Rome published about 15 years ago that looked at prospectively at admissions to a subspecialty pediatric hospital and found a prevalence of about 0.5%. Sounds small. That's 1 in every 200 kids. I don't know how much bigger it is at a very end of the line quaternary children's hospital, but my guess is it's higher because that's where these kids end up after years and years. The mortality is also not trivial, 6 to 9% across 2 large retrospective series, and significant morbidity as well. Things like chronic pain, destructive joint changes, scarring of the skin, neurologic devastation, chronic GI problems from multiple gastrointestinal surgeries. It's also important to note that these children aren't the only ones at risk. Oftentimes they have children, or excuse me, oftentimes they have siblings. And those siblings, when a diagnosis is made, more is dug up about siblings who might have been affected. Or one child manifests and they realize, we've seen this family before. Another parent, another child was here. And the other thing, just from a social development standpoint, these children are likely to spend a lot of time with us in the hospital, not in school, not forming social relationships, not establishing any form of identity independent of that as of a patient. So what did we do? We looked at these case reports published over the past almost 50 years now, starting in 1977. To be included, they had to be written in English, Spanish, or Portuguese, just because I happen to speak and read those languages fluently. They had to contain invasive procedures or imaging procedures that are most likely to be performed with sedation and or anesthesia. And they had to meet at least 3 to 4 criteria for the diagnosis of MCA, which I'll get to in the next slide. This has been an extremely labor-intensive process over many years. We started in the summer of 2020 with looking at these case reports, analyzing them, summarizing them, and dissecting them for diagnostic relevance, as well as their procedural number. So these are the diagnostic criteria for medical child abuse. The first is fabrication or induction of illness in a child by a parent or caregiver. Second is that interaction with the medical system leads to multiple unnecessary tests, procedures, and even surgeries. Third, the parent or caregiver they don't know what's going on. They keep coming back. They want more workup. They need to figure out why they keep bleeding, why they keep having altered mental status. Why do they keep vomiting? And then fourth, which this is the criterion that I felt was most important when I was reading case reports, the proof. The child's symptoms improve when separated via the court or a trial of separation in the hospital or when under strict surveillance, or the parent admits to it when confronted, or is confirmed to be fabricating or inducing illness. You have a question?
Yeah, you may get into it, but regarding that second bubble,
Mm-hmm.
Do you ever address withholding of necessary, the opposite or whatever, the counter, withholding of necessary tests?
I don't.
Repeat the question for people on Zoom.
So the question is whether, for the second item here about tests and procedures, whether there's withholding of pertinent labs or workup. I don't know if that's medical child abuse or if that's neglect, but I also think there can be an element of both, of letting, and I would get confused in some of these case reports where I'd be like, is this medical child abuse or is this a family that didn't totally get it or wasn't able to come to the hospital? So yes, this is a spectrum. And again, if I had 1, 3, and 4, but 2 didn't totally add up, sometimes, I mean, we would say 3 of 4, yes, but we would have granular discussions about like, does this seem right? Does this seem like medical child abuse? And I think that ambiguity is what makes the diagnosis so hard, right? But most commonly, it's somebody who wants more workup, more. We haven't figured it out. It keeps happening. Happened again last night when you weren't in the room, right? So to analyze this data, I read all of these case reports, and they were, I think the initial COVID, these 3 types of searches, PubMed, Embase, and Covidence, brought me thousands of articles. And then I spent a good time figuring out which ones were actual case reports of likely medical child abuse and if they contained invasive procedures. And then if so, that was included for potential case reports for inclusion. If there were no procedures, it was excluded. And if it was not MCA definitively, we didn't go into it. And then once we had our case reports for inclusion, I summarized them in detail in a Google spreadsheet, and then Dr. Burgart and I would meet in person over the phone for hours at a time to dissect these case reports and to determine whether they met minimum diagnostic criteria for medical child abuse. And we also talked at length about procedures, number, type, and what could be included and what couldn't. So this is a case example, just so you get an idea of how we did this. And the color coding will make sense in a second. So this is one of the cases that we included in our final data. This is a previously healthy boy who developed diarrhea at age 1 after 1 year of breastfeeding. It did not improve with dietary changes and a restrictive diet, elimination diet. So they did a medical workup to rule out cystic fibrosis. They did a growth curve analysis, an immunology workup, and an evaluation for a hormone secreting pancreatic tumor. All of that was normal. So the child was eventually admitted for further evaluation, underwent a small bowel biopsy and a rectoscopy with biopsy. The child was started on TPN, and when they said TPN, I inferred central line placement because you can only do TPN through a central line, and metronidazole, and then the child improved. This case report is published when the child is 6 years and 5 months old, who was readmitted. So I don't know what happened for 5 years. That's the limitation of a case report. They readmitted with frequent watery diarrhea and started on TPN. I don't know if through a new line or an old. Since I can't confirm, I'm just sticking with the one procedure I had from year 1. The central line was replaced 3 times for malfunction. The child underwent additional workup, chest, abdomen, pelvis, CT, pancreatic ultrasound, and specific labs to rule out a tumor. At that point, the medical team began to note wild fluctuations in his serum sodium concentrations, and both the urine and fecal sodium levels were very high. They studied the stool, which contained very high concentrations of sulfate, thus raising suspicion of possible medical child abuse. The child was separated from the parents and improved spontaneously within a few days. And eventually on confrontation, the mother admitted to giving the child glauber salt, which is some sort of, it's like a mineral. I looked it up last night. So I color coded this to go with what I color coded in the prior slide, which is this patient medically complex? No, he was described as previously healthy. What was the age of onset? They said age 1 after a year of breastfeeding. I don't know what 1 means. I inferred 12 months based on the story. And I would try to be as conservative as I could to not overcall things. The child was diagnosed at 6.5 years old. So the duration of abuse is 5.5 years. You can see the invasive procedures that were performed were divided into GI and invasive line placement. So total number of invasive procedures on this child was 8. Almost, I would say all of those are with a doctor like me for anesthesia, unless they're doing a PICC line placement at bedside, but I doubt it because it's a TPN line, probably a permanent central line for home. And then the criteria, this child met all 4 criteria for medical child abuse, and importantly, the 4th one. We separated the parent from the child, and we had admission from the parent. So that was one case. That's what we did over and over again for all these cases. We pulled out of the thousands of articles I pulled out from here. We have 220 case reports that I provided detailed analysis of. And then we included 198 patients and siblings. Sometimes those case reports might have, like a single article might have 4 cases and 2 are relevant. So it's not exactly 198 papers, but it's close. And this is a representation of when these case reports were published. You can see this is a really long-reaching phenomenon with varied publication years, starting in 1977. So this is the beginning of our results. These case reports were drawn from countries throughout the world. And of the 198 children included, they underwent a total of 809 procedures, about 4 per child. So that means each of these children is getting anesthetized on average about 4 times. In my OR, where I don't think the benefits outweigh the risks, and to make it personal. The average age of onset is around 2 years old, and the abuse on average continued for about 2 years. And most devastatingly, in our study, 29 children died, 10 index cases, and 19 siblings who died under suspicious circumstances as well. This is a graph showing age at onset of abuse and the age of patient at diagnosis on the y-axis. You can see most of these children are young. Most of them are diagnosed, hopefully, within a short time frame, but the arrow points to a pretty devastating duration of abuse on the order of more than 10 years for a patient to be diagnosed with medical child abuse. And you can also see in this slide, we have some older children in this study, but the great majority of them are young. This is a phenomenon of young children. They're pre-verbal. They can't defend themselves or advocate for themselves. They're physically small. Their symptoms are able to be manipulated more easily. They don't understand what's going on. And you can see the age at diagnosis is also, it's more commonly seen and diagnosed in young childhood. But we have some teenagers on here, and there's a phenomenon whereby somebody who's been abused by their caregiver for this long starts to participate in the abuse and identify with that narrative of their own illness, and that can complicate diagnosis. This is the quantitative data of the procedures these children underwent by surgical subspecialty. By far, the most common surgical procedures performed on these children are in the endoscopy suite and gastrointestinal surgery, typically performed by general surgeons. And then the other things of considerable frequency are central line placement and replacement, ENT and airway surgery, and then also imaging radiology procedures and neuro procedures, typically LPs. I'll just say briefly under imaging, this is just a professional thing as an anesthesiologist. That's a non-invasive procedure, requires general anesthesia. That's what we do for young children going to MRI. It might be a multi-hour scan. Sometimes we intubate them, sometimes we don't. Their airway is in a scanner with the door closed, far away from me. So the idea that it's not invasive is true, but it's invasive for me if anything happens. It's not we're not opening the belly, but we are assuming anesthetic risk every time we do a brain MRI. And when we break down the commonly performed procedures a little bit further, so LPs were very common, bronchoscopy as well, and we'll get into why that is in a second. General surgery, by far the most common procedures were feeding tube placement, G tubes, J tubes, revisions, exchanges, Nissen fundoplications, and then in hemonc, several bone marrow aspirates and biopsies as part of an infectious or inflammatory or potential oncologic workup. And then in the radiology suite, by far the most common were brain and spine imaging. So this is something, I'll just go back. This is something I wanted to bring to your attention that came up over and over again in the case reports, which is this title at the top of the page was my favorite title. I thought it was the most creative. You know, it's not a great thing to talk about like creative titles in medical child abuse research, but this one is, I thought, said it all. The central venous catheter is a source of medical chaos and Munchausen syndrome by proxy. So this was actually written by Hickman, as in the Hickman catheter, with a child abuse expert at the University of Washington. And they found that the central venous catheter in these patients is a highway to bad stuff because it's access into a child's circulatory system. So this is a Hickman catheter. You can see it's a double lumen catheter. It's great. For onc patients, it's great. We don't have to poke them. We don't have to look for vanishingly small chemotherapy, altered veins. We can draw off it. We can run infusions through it. I can induce anesthesia through it. I love it. It's a great line. It goes right into this cavo-atrial junction, as you can see here. In our study, 91 children had central venous catheters placed. It's not a benign procedure. I don't know how many people in this room have done it. I see a few anesthesiologists here. I've done hundreds of these procedures. Children have died from central line placement. It is a safe procedure in capable hands. It is not without complications. They can go in the wrong spot. They can perforate blood vessels. They can end up in the lung. They can cause dysrhythmias, hopefully transient. A few children in our studies had more than 8 central lines placed. I think the most I saw was 14 line exchanges for recurrent polymicrobial bacteremia. And so Feldman and Hickman in their paper looked back at their confirmed MSBP cases, because this was published in the 90s, and 17% of them had central lines placed. 2 of them died from central line complications, one from polymicrobial sepsis, the other from an air embolus, which implies that someone put air in that line. Over half of them developed known central catheter associated sepsis, whether that was induced by a parent or caregiver, or whether that's just a known complication of a central line that we know about. Maybe it happened, but should the central line have been there in the first place? We don't know. Often these cases, they comment in their study, and I saw in mine too, is polymicrobial sepsis. If a child has recurrent polymicrobial sepsis, why? Why are there 3 bacteria in their blood? Why are they urologic pathogens? Why are they HEENT pathogens? Why does that keep happening? Or the bacteria were isolated, were sensitive to the antibiotics these children were already on, and they were seemingly improving, but they kept getting bacteremia. This, I feel like, is a way that I thought about the common presentations that we saw in our study, because I want to know when to worry about this. As an anesthesiologist, I want pediatricians to know when to worry about this. These are the common things where when Alyssa and I were reading case reports, like, oh, this again. This is the way they're setting the stage again. So feeding intolerance, failure to thrive, nausea, vomiting, and diarrhea. That was most commonly associated with G or J tube placement, Nissen fundoplications and revisions, GI endoscopies, central line placements for TPN, abdominal imaging, or even additional abdominal surgeries. Open them up. Why is this happening? XLAP, go back upstairs. Another common presentation I just mentioned is recurrent fevers, bacteremia, and infections in children with often central access. These are the children who come in for line exchanges, line removal, full body imaging to look for potential abscess that's causing this, and INDs of sources in the abdomen, in the legs. Another common presentation was things falling out of the ears, usually discharge or blood, recurrent ear infections, and those children would have myringotomy and tubes, mastoidectomies, other exploratory ENT surgeries, ear exams under anesthesia, and head and neck imaging. Another extremely common presentation was just bleeding from places, vaginal bleeding, GI bleeding, hemoptysis. And those children were likely to undergo all the oscopies, EGD, colonoscopy, enteroscopy, laryngobronchoscopy, cystoscopy, a gynecologic exam under anesthesia, or abdominal surgery, a more invasive surgery to look for a potential source. One of the common presentations in infants is apnea, seizures, often seen only by a parent or caregiver, altered mental status, obtundation. This can be suffocation. It can also be poisoning. So giving of clonidine was a very common thing, giving of tricyclic antidepressants to these children. And those are kids who are likely to get an LP, brain imaging, to be intubated and ventilated due to apnea, altered mental status, inability to protect their airway. I think in our study, we counted 26 urgent or emergent intubations for these kids as well, which is a very different procedure than the one that I do in the OR with an NPO child. An intubation on the floor or in the ICU or in the ED is a very different procedure than a very controlled intubation in the OR by someone like me. Recurrent unexplained hypoglycemia was something that happened more than once. And those are children who are going to get abdominal imaging to look for potential pancreatic tumor, lumbar puncture as part of a hypoglycemia workup, pancreatic venous sampling to look at insulin levels in the vasculature of the pancreas. And more than one child in our study underwent a pancreatectomy. And then we're on lifelong pancreatic enzyme supplementation as well as insulin. After all that, I think it's important to discuss this interplay of medical complexity and medical child abuse, which comes into play commonly at subspecialty children's hospitals like the one where we work. Is it medical child abuse, or do they just have a really weird disease? Is it both? So this is a phenomenon called children of medical complexity. We all know them. We take care of them every day. They're in our hospital all the time. They're in our complex care clinic. They're the kids who have 8 subspecialists managing their problems. They're often seen at hospitals like ours, and they constitute a large amount of pediatric healthcare spending. Sometimes these kids have really rare diseases. The genetics team is involved. There's one other case described in the literature. Those parents want to know what's going on. They're going to keep coming in. They are scared too. They don't understand what's happening. They want a diagnosis. And so Peds, I believe at the Children's Hospital Wisconsin, published an excellent overview article about these phenomena when they are separate and when they combine. And it can be really challenging to determine whether a child is a child of medical complexity or a victim of medical child abuse, or both. Up to 30% of these children in Rosenberg's 1987 paper were both. They had some degree of medical complexity, and they also had elements of medical child abuse. As this data has shown you, as I hope you don't know personally, but you might, delayed diagnosis of medical child abuse can lead to significant morbidity, physical and psychological, and it can also lead to death. So if we delay diagnosing it, we risk harming children. And this quote from the Peds article, I think, is also really important, which is that the damage to the family and the caregiver-physician relationship arising from an erroneous suspicion of MCA can have significant negative consequences. As we know, we fear this with our therapeutic relationship with the family too. This is something that is scary to bring up, whether or not the suspicion is correct or not. And sometimes it's really hard to know because of this interplay of real medical pathology and induction or fabrication. In our study, it was, again, quite difficult at times to figure out, did this initial presentation, was that medical complexity, or were they making that up? That was hard sometimes. Like, I don't know, were they vomiting and failure to thrive? Was that actually the problem? And then they got used to this hospitalization and the medical role, and then they escalated? Or was that the problem? And so coding medical complexity was a difficult thing to do, and led to a lot of discussions between myself and Alyssa. And there were multiple case reports in our study where the initial hospitalization was for sound reasons. So people who, a kid got in a car accident, a kid had recurrent ear infections and got a myringotomy, and then they just kept having discharge for weeks and blood. And then they did a sample and it was not the child's blood, but it started with a seemingly sound medical reason. And that's where we suspected that the parent or caregiver became medicalized or exposed to this care environment, and then that escalation began. I sort of stopped analyzing this because that's not, I try not to look into the motivations there, because that's not what the diagnosis of medical child abuse is about. But that question is really interesting. Did something happen where this sort of became like the caregiver's home in a way, the hospital? Oh, and then just quickly, and looking at our own children in medical complexity, we had about 1 in 5 children in our study. We coded everything as medical complexity. So like a preterm infant, or somebody who was born with polydactyly, somebody who had to have a legitimate interaction with the medical system, that was coded as medical complexity. So I think we were a little more liberal with that definition than the children that Petska's talking about like the G tubes and the airway clearance and the vest treatment at night for a genetic disorder. And a large number of our medically complex patients were ex-preterm infants with multiple problems. So in looking back at this data and how, there's a lot of it, but like, what are the limitations here? And I got so frustrated at case reports at times when I was doing this data, which is, the data is only as good as the case reports allow it to be. There were several case reports where I'd be like, and then what happened? The child and the parent went home. I'm like, okay, then what happened? And so I can only go with what I'm given to create quantitative data. And as we know, case reports are a discrete moment in time. And this is a phenomenon that lasts years sometimes. There are big gaps in these case reports. That first one I showed you, 1 to 6.5, I don't know what happened from 1 to 5. That's not part of the case report. There might be way more procedures. There might not be, I don't know. I only can document and quantify what's in the literature. And this data spans about 50 years, during which we've seen the explosion of EMRs, and that transforms how we surveil previous hospitalizations. It has radically changed how we look at data for kids. I mean, Alyssa and I came up with this moniker called the Care Everywhere sign, where I'll just open up Care Everywhere and be like, oh, 10 hospitals. Okay, I got to look into that a little bit more. We've also seen a significant paradigm shift, as I mentioned, from this Munchausen syndrome by proxy name to medical child abuse, which I think is positive change. And as I mentioned from the front, there's a case report from Oman, might be really different from Turkey, from Sweden, based on how families are structured, how the legal infrastructure is structured. I had a case report from the Middle East where they wanted to do surveillance of a parent and they felt they could not do that. They could not do video surveillance for sociocultural religious reasons. And so that's really different than what might happen here. There was also a wave of covert video surveillance, like a huge number of publications about the ethics of this in the 80s to 90s. And that literature has petered out, and I think so has covert video surveillance. And then, as I mentioned, I'm likely underestimating. I was as conservative as I could be in tabulating these numbers, which is devastating because it's 810 procedures. I think that's an underestimate. So to finish up, I spent a lot of time in this literature, and Alyssa told me, I don't think anyone has read as many case reports of this as you have. So what kind of information do you want to impart to people who take care of kids to keep them safe? And we came up with this rubric of 4 elements to think about when you're discussing medical child abuse, if you're writing about it, if you're thinking about it as a care team. And that's these 4 elements here. Seeking, inventing, acting, and proving at the top, which is, in our opinion, the most important. So inventing is inventing, seeking, acting, and proving. Those are the 4 elements. So in inventing, you have, as a provider who's thinking about this, try to give or think of a compelling description of the elements of fabrication or induction. For seeking out care, show that the caregiver repeatedly presents for further workup and that the child is subjected to tests and procedures. Under acting, demonstrate that the caregiver purports not to know the cause of the child's symptoms and continues to pursue medical workup. And finally, the most difficult and the most important, proving. Document or discuss specific evidence that confirms the fabrication or induction of symptoms. We came up with this framework also to inform writing of medical child abuse case reports so that they would be more instructive vis-a-vis our paradigm. Just to give you some examples of this, for inventing recurrent apneic events, seizures, reports of altered levels of consciousness that occur only in the presence of a given caregiver, or unexplained recurrent bleeding or discharge, again, that is not seen by the medical team typically, or non-healing wounds or recurrent infections despite appropriate antibiotic therapy. For seeking, this is where I loved seeing quantification in the case reports. 120 clinic and ER visits in 5 years. That opened my eyes when I would see that. 34 venipunctures, 2 EGDs, 3 exploratory laparotomies, 4 brain MRIs. There's a lot of heavy information in those numbers. And then for the last 2, for acting, the caregiver is requesting more lab tests, more intervention to determine underlying medical cause. Or this happened quite a bit. The parent provided consent for invasive surgeries that were not performed because MCA was diagnosed prior to the intervention. People consented for a liver transplant, for pancreatectomies. And we had a child in our study who had a small bowel transplant and was subjected to lifelong immunosuppression. We had another child who underwent 40 surgeries. And for the proving piece, this is where the money is, in my opinion. So especially lab evidence, a toxicology report. There are TCAs in the urine here. This child was on TCAs. There's clonidine. There are pill fragments in the mouth of an aspirating child. That was a case. Blood typing of the blood in the diaper does not match the blood type of the child. This is probably even different now in the age of DNA, because some of these case reports were done prior to like DNA testing. Witness behavior, smothering, injecting into a G-tube or something. This is really uncomfortable to talk about. It's awful. And it has been seen, and that is how it's been diagnosed. Removing a blood sample from an indwelling line. I had a case report of blood on the walls in the bathroom from withdrawing from a central line. And then importantly, symptoms resolve with separation. As I mentioned, I think this is the most important thing and often the most difficult to obtain. So for some conclusions prior to questions, I hope I've been able to demonstrate to you something that was personal to me and then became quantitative fact. These children frequently receive care from doctors like myself in the operating room, in radiology, throughout the hospital. By far the most common were GI surgeries, GI procedures, and abdominal surgeries, although frequently invasive line placement, imaging procedures, and ENT surgeries were performed. And another thing that is mentioned in Rosenberg's paper is, and perhaps you've experienced this in your jobs, is that abuse can escalate when a child is admitted to get more and more invasive workup done. So it's really imperative that we think about this if we keep having that kid coming to the OR. Finally, most physicians who take care of children in my workspace have limited to no understanding of this. And I've experienced this when I've talked about my research interest with colleagues of mine and at a recent anesthesia meeting. And I would argue that the perioperative medical team has an important role in detecting this, given how many routine surgeries we do for sound reasons all the time. And finally, increasing awareness about this issue in the pediatrics floor, in the ICU, in clinics, and in the OR will allow all of us to collaborate in what I think is the most sacred duty of a pediatrician, of a doctor who takes care of children, which is to keep children safe.
It's on. Oh, perfect. Thank you so much. That was like fantastic talk, especially for those of us who do like work in this space and who do like straddle the lines between like anesthesia and on the pediatric side. Well, one of the questions I actually had was, it seems like one of the biggest takeaways is the number of procedures that that these children like undergo. But is there any like association that you found? I know there's a paucity of like this in the literature, and like the case reports aren't as detailed as we'd like them to be, but in terms of like the density and like a time perspective of like these procedures, I don't know if you're noticing anything like that in there, because I'm just thinking of like a patient coming in with a new diagnosis of something like real, and there's like a very like big dense spot of like a bunch of procedures that are done within a very short time period, but then there's a diagnosis that's made, and then they have like they're monitoring after that, but there's a sharp decline in the number of procedures. Whereas I can imagine someone with like medical child abuse, there's this big initial like bolus of procedures, and then each time they get admitted is like another big bolus.
Absolutely, that's an excellent question. I think there are really different types of case reports. There are things where it was diagnosed really quickly. They say they're bleeding, the blood types don't match. We did an EGD. We did an EGD, then we made the diagnosis. So one procedure, right? Then there are cases that are the kid's seen in clinic several times. It has one procedure done, comes back, is like a patient in the clinic in some surgical subspecialty office for years, and then kind of incrementally gets modifications. One of the things I saw was a lot of like gastrointestinal surgery that is then revised. Okay, now I need to revise the Nissen a couple years later. And then, so, the kids with central lines, those are like, they don't define necessarily the interval at which these procedures took place, but recurrent bacteremia, you can imagine that's something that's being intervened upon pretty steadily over a hospitalization. But sometimes, these are kids who come in, they get their intervention, they go home, and the hospital doesn't know what's happening because they're in clinic, or they're at home, or they're going to other hospitals. So it's really difficult sometimes to quantify time length. And then like that basically age of onset to age of diagnosis, we did the absolute best we could to ascertain that, knowing that we're probably not getting it perfect because we're limited by the case report. So I would say that the hallmark of a lot of these cases is like a couple of procedures at a time over years. And then the case report is often written from the perspective of a subspecialty children's hospital to which this child was referred. And then they start doing more workup. They start doing some procedures and they're like, wait a minute, this isn't right. But that might be 5 years later after 10 other things have been done in other settings. So it felt more like a steady drip from the faucet in a lot of cases, or one drip diagnosis, which is my favorite, because like we figured it out, we separated them, the child is safe, but that was pretty rare.
I'm wondering like how you are changing your practice or what you advise others to, especially when so many or a lot of people provide episodic care rather than the continual care, which I think, in some ways contributes to this. So I'm just wondering what you recommend.
You're talking like me as an anesthesiologist?
Yeah. Or what you recommended to your
For sure.
anesthesiology colleagues at your meeting.
Yeah. So when I gave this talk over the weekend, it was really interesting. I would categorize the audience as sort of like stunned silence, but with a look of like, I know what you're talking about on their faces, right? And what I was saying to them was, there's a child abuse pediatrician on call 24 hours a day at these hospitals. There's a child abuse team. But the thing I said is, I was like, if something doesn't seem right to you, that's important. And I said, the general pediatric service is probably taking care of this kid. The GI team is probably taking care of this kid. There are doctors that are following them, and you can express your concerns to those people. I've had at least 2 cases where I've been like, this is what I think this is. In the operating room, and one of them inspired this research. So what I tend to do is one of the people I met this week and talked about, does it pass the sniff test? Does it make sense? We do a lot of things in the OR that don't make sense sometimes, that don't seem to make sense in the moment. And sometimes our hand is forced by emergent situations. But I would say what I'm working on now is, after this data, I want to start making a rubric for how to think about this in terms of reporting and detection in the OR and then also how should anesthesiologists and surgeons be part of medical child abuse multidisciplinary teams in the hospital in order to come together to educate ourselves about this phenomenon, but also to talk about cases we're worried about for inpatients or outpatients. I never work in the outpatient setting, so that's not my strength, but I'm sure these kids are taken care of in our clinics too.
Thank you for a wonderful and really moving talk. Do you think the explosion of diagnostic tools that we have for not just kids, but all patients have increased or decreased the incidence of medical child abuse? Because you can imagine that on one side, there's more tests, so there's more things you can run. On the other side, if you have more tests that can quickly rule in and out diagnoses, perhaps it would make it harder to fabricate these instances of medical child abuse.
Yeah, good question. So in our study, we actually had a special subcategory of procedures that detected medical child abuse. So certain, like an EGD that was confirmatory or whatever. These were few and far between, but a procedure that was done to then determine that the diagnosis was not of medical origin. So I would say there are certain things that can be done to make it a more likely diagnosis, right? Regarding your question about medical sophistication, I read a memorable case report from sub-Saharan Africa where I was like, oh, this kid in the US would have had way more done, way more radiology, way more interventional radiology. And so procedural availability and the narratives we tell ourselves in these subspecialty settings, where we do the brain MRI, we do the LP, we put in the central line, we put in the G tube. That's not accessible in some of the places where I was reading case reports. And it was really interesting to be like, I'm hunting for a procedure here. I'm looking for one, but they don't have the same capacity to do these things. So I think we reflexively think we're doing the right thing and escalate. And I will say, sometimes in the OR, you do something, you unzip someone and they don't have any findings, but you don't think like, oh, it's all made up. You think, I need to look for something else. I need to tell the primary team to look for something else. And like that quote that I started the talk with, it's almost like in horrified retrospect that we put a mirror up to ourselves and realize what we didn't see.
One question here online. A number of recent reports have highlighted the bias, racial, socioeconomic, et cetera, in reporting child abuse. Can you reflect on this issue in your research?
It's another great question. Interestingly, I noticed a trend in these case reports, and I think this was what was going on in medicine at the time, of identifying the race of patients in like the 80s and 90s. And I did not include it in the study in the same way I did not include the identity of the caregiver in the macro data, because I felt like there were ways that race was discussed sometimes in these case reports, or the gender, particularly mothers, that I felt to be troubling, and I felt to be almost like directing me towards thinking that it's always the mom, you know, and it wasn't always the mom. It was often the mom, but it's not always. And so I know that as a doctor who takes care of families of all types, but I know my population at Packard, I'm absolutely sure we carry unconscious biases here too. I witnessed them as a resident here. I had some troubling experiences, not about abuse in general, but where sort of like parental motivations were questioned in a way that I felt was problematic, or parental conduct. And so I think that is something that is at the forefront of a lot of our discussions about the care we provide. But in the medical child abuse literature, I don't think it's robust enough yet to have that nuanced of a view of discrimination and our tendency to assign like that certain values to behaviors in some families and not others.
Oh, thank you. I want to applaud your work. This was such a deep dive, and not enough time and attention is spent on this. I appreciate the desire to focus on the child while also recognizing that I think because these cases are so complex that with parents, there can also be just profound anxiety. And we talk about vulnerable child syndrome. And so as a psychologist on the psychiatry service, have worked with many of these families. And so because there are many levels of learners here, want to raise awareness that it is not always medical child abuse. And so the importance of really understanding the underpinnings, and that many of these kids where perhaps it was medical child abuse in the early years go on to develop more of a factitious disorder themselves because it becomes integrated into their identity. But I really thank you for raising awareness, because I think everyone needs to stop and take the time and communicate. And I really want to call out our Gen Peds hospital medicine people. Debbie Sakai is one of my heroes because she has tackled these cases so many times in the past. So communication, it's great that you're looking at this in the OR for people to come together and really just talk when we see these red flags. Thank you.
Thank you, guys.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.